You know, it's a pleasure to be here. One of, I think, the most exciting opportunities that I have to work on within the Department of Health is the social determinants and really enhancing the role of community-based organizations in the healthcare sector, because I truly believe that the work that community-based organizations provide in the healthcare system is paramount, and how do we really resource, local CBOs to be able to provide enhanced work in the community, because I think that the key to that work really and truly is the cornerstone of improving individuals' health within the community. So I really, oh, I thought that clapping was for me. I was like, oh no, I'm in the wrong room. But in any event, I think we're really going to save a lot of time for Q&A. And at first, when I was looking over what I was going to talk about today, I was thinking, oh, I have a great story on how important it is to provide social determinants to individuals, and I'm guessing everybody already knows that it's a no-brainer. So, one of the things I think I'm going to kind of concentrate on are what are the rules of the road, what are the future opportunities for community-based organizations in value-based payment, and I think you're going to really love to hear from Alissa on the work that she's doing in God's Love We Deliver. I think one of the most important things that I learned from Alissa is you can feed somebody for half a year for the cost of one night in a hospital, and I think that those statistics are true for almost for many social programs that are provided. So how do we really enhance the education to the healthcare system, to the hospitals, to the health plans and others, so everyone really and truly understands and appreciates the role of community-based organizations, the role of social determinants of health within the healthcare space. So I think there's a great opportunity here in New York as we move to VBP. As you know, 80 to 90% of dollars will and are flowing or will be flowing by 2020 in a value-based payment arrangement. So how do we harness some of those resources to community-based organizations and to social determinants? Because I think if you don't address those areas, you truly will never be able to make someone healthy, improve their health outcomes, and improve quality of life. So what we have planned for this session is really a quick CBO whiteboard video by Jason, just to kind of give everybody a quick primer on CBOs, and then we're going to move into what are some of the key pieces within the roadmap for community-based organizations in VBP. I'm going to talk a little bit in depth about CBOs, whether you're a tier 1, 2, or 3, and depending upon who you are, how do you play a role within value-based payment. And then Alissa is going to talk about the great work in God's Love and really give you a true example of how a community-based organization is currently engaging in VBP contracts and how that really works in real form. But I think it's a great opportunity, and it's an exciting time to be involved in healthcare, to be involved in New York Medicaid, and especially to be involved in community-based organizations and social determinants, because our VBP roadmap has, I think, the only requirement in the country that health plans and VBP contractors must contract with at least one community-based organization. And so I'm going to walk through those requirements in a minute, and as I mentioned, I think everyone kind of recognizes the importance of social determinants, and we certainly do within the Office of Health Insurance Programs. And just yesterday, we were very happy to announce a new bureau focusing solely on the social determinants of health. Previously, we worked on housing, and we very quickly realized, housing is only one core component that we really need to move resources towards, but there's many others. And so I'm very happy to be working with the team on that initiative. And so if you have any, questions after, I'm certainly going to hang out for a while. But I think it's a great opportunity to really try to, keep the highlight on the importance of social determinants. And Greg kind of touched on, one of the reasons why, and I'll quickly go over it. But in America, we spend more on healthcare, less on social services, and we have poorer health outcomes. And I think many studies have really pointed to the fact that 60% of someone's health is directly related to social and environmental factors. And until we start moving resources to those areas, we're never going to make a true impact on an individual's life until you start to address whether it's housing, nutrition, education, safe housing, healthy housing. There are many examples of opportunities, that exist before us, but I think, this is the key reason. How do we really move the dial and start increasing investments in social areas, and then that way we'll spend less in healthcare and we'll have healthier Medicaid members and a healthier community in general. And so one of the first pieces of the roadmap that are pretty important to mention is that if a VBP contractor is in a level 2 or 3 agreement by January of 2018, and I think folks are already working and have been working on meeting this requirement for quite some time, since we're in the middle of December. But this is really, I think, just the start. This is really just the floor and not the ceiling. VBP contractors in level 2 or 3 arrangements must have at least one contract with a community-based organization to address a social determinant by January of 2018. And so, I think those conversations and those relationships have been building for quite some time. But I will say that, one of the most important pieces that I want to, communicate to everyone is that what we're trying to do is to make sure that we continue the conversation, we continue, educating everyone within the Medicaid space on this requirement, and to make sure that, whether health plans, PPSs, VBP contractors, community-based organizations, really think, I don't want them to just check the box and say, oh, I met the requirement, I'm done. I think I want, everyone to continue the conversation to say, what VBP arrangement am I in? Is it total cost of care? Is it maternity? Is it HIV? Is there a subset of that population that is driving costs, that is homeless, that is food insecure, that lives in unsafe housing? And then how do those relationships continue to grow and to build? And so rewarding social determinant intervention. So there is a requirement in the roadmap that MCOs must identify and financially reward social determinant projects. And so since CBOs will not see savings in the short term, they'll be incentivized by MCOs up front. But each, I think, arrangement will really be detailed within the contract that CBOs and health plans or VBP contractors negotiate, but there are requirements in the roadmap that there should be investments for CBOs up front in order to move forward with their intervention. And so I think recognizing that every community is different, every area in the state, faces different challenges. There's a lot of flexibility here to think about what is the main driver of Medicaid members, what is the real intervention needed. And so every intervention that's selected will certainly be different throughout the state. We didn't prescribe, you can only do X, Y, or Z project. I think we really are encouraging the flexibility for communities and for VBP contractors, for community-based organizations, to really think through what are the main drivers and what are the main solutions needed in order to impact the health of Medicaid members. And so one of the things that we're very interested in doing is understanding what projects will be negotiated, what projects will be implemented in the value-based payment social determinant space. And so we have required a template for MCOs to submit to our health plan contracting team within the department. So first and foremost, we understand that folks are meeting the requirements in the roadmap, but more importantly, us as a department are very interested in learning what interventions are taking place within the community, what's working, what's not, just for us to really, gauge what's happening in the field and to really understand, the volume of the projects that are moving forward or the lack of volume, and how do we kind of get involved to ensure that we're really doing enough to meet the social determinant and CBO requirements. So I mentioned here that starting January 2013, VBP contractors in level 2 or 3 arrangements must contract with at least one Tier 1 CBO. One of the things that we have heard quite frequently from community-based organizations throughout the state is, what if I'm a Tier 2? What if I'm a Tier 3? Does that mean that I can't participate? And the answer is no. We very much encourage all community-based organizations to participate. It does not matter if you're a Tier 2 or Tier 3. One of the reasons why we concentrated on Tier 1 was really to make sure that community-based organizations who, traditionally didn't have a lot of previous experience in the healthcare space weren't left out of the partnerships. And so this is really just kind of a clarification of what is a Tier 1, what is a Tier 2, and what is a Tier 3. So a Tier 1 CBO is a nonprofit, non-Medicaid billing, community-based organization. A Tier 2 is a nonprofit, Medicaid billing, non-clinical service provider. And then a Tier 3 is a nonprofit, Medicaid billing, clinical or clinical support service provider. And so every tier here is valued and is important. And so I just want to encourage, if you aren't a Tier 1, but you are a Tier 2 or 3, please don't think that you can't participate in value-based arrangements, because you can. And one of the things that we're really trying to communicate is how do we maximize participation, because we really do think, and I personally do think, that the more partnerships, the more networking opportunities, the more contracts that exist between health plans, community-based organizations, PPSs, value-based contractors, I think the more that starts to happen, it'll catch on. And I was really excited. I read the Albany TU, I think it was Monday or Tuesday of this week, and there was an article in the blog talking about the partnership between community-based housing providers and CDPHP. And it was great to see that in the newspaper, and John Bennett, the head of CDPHP, was personally quoted as acknowledging that housing is healthcare, and that members within CDPHP who were homeless in shelter or living on the street, couldn't really turn their health condition around until they moved into housing. And so, I was very happy to see that in the newspaper, and those are more of, the stories that I very much am encouraged by, and I think you're going to hear, some great stories from Alissa too on the nutrition side. But I do think there's a great opportunity here to really increase, participation with CBOs and with health plans in the state. And so this is just a quick review of other CBO and social determinant standards in the roadmap. So all new and existing VBP level 2 and 3 arrangements must include, as I mentioned, at least one social determinant of health intervention, and flexibility, is allowed. As I mentioned, it's not prescribed, and at least one Tier 1 CBO beginning January 2018. So VBP level 2 and 3 contracts without social determinant and CBO requirements will not meet the definition of VBP, and health plans that do not meet the VBP goals outlined in the roadmap are subject to penalties. And so we are, very much paying attention at the state level that MCOs are meeting the requirements outlined in the roadmap. And so this is really just a top 10 list of what providers and CBOs should know as we are kind of working towards meeting our January 2018 goal and thereafter. But addressing social determinants does not require a CBO to enter into a risk arrangement. So we have received, quite a few questions. If I'm a CBO, do I need to assume risk? The answer is no. I already quickly mentioned this, but a Tier 1 CBO is defined as a nonprofit, non-Medicaid billing, community-based social and human service organization. One of the things that we will be launching rather shortly is really an inventory of all CBOs, and we're going to put out a survey from the department to the field to make sure that there's a comprehensive inventory of community-based organizations, kind of separated regionally. And so if I'm a health plan, if I'm a PPS, if I'm a VBP contractor and I'm not familiar with the CBOs in my community, we're really trying to increase education for everyone so they understand the value of CBOs in their community, what are the services provided, who's the person to contact if they want to create partnerships. And we're trying to do that in both directions. If you haven't attended our VBP boot camps, one of the things that pamphlets that we put together by region, and I don't know if it's on our website, but I can certainly share it after, is regionally based. Who are the main hospital systems? Who are the main health plans? Who are the main CBOs? Who are the PPSs? Just so folks understand who to really be able to contact to increase networking, to kind of get relationships moving. And so, as I mentioned, Tier 2 and 3 CBOs certainly can participate in the VBP social determinant space. A CBO can be contracted to address a social determinant of health in one or multiple VBP arrangements. And so, when we think about contracting, there's many opportunities for contracting. A CBO can contract with multiple VBP contractors. A CBO can contract directly with a health plan. There's a lot of flexibility on how to move forward with those arrangements. So developing a value proposition is key, and I think I think this is a really important piece of the puzzle, and it's really and you all, I think, are the experts in your field. You're the experts in your community. I think you already probably know what are the interventions that are key, and I think communicating that value proposition to a VBP contractor, a health system, health plan is extremely valuable. I don't know if all entities know what you know. How many if I'm a health plan, how many members, or if I'm a VBP contractor, how many members in my total cost of care are homeless? Do I even know that information? And so, are food insecure, or there's so many different things to think about. And so, you're the experts here, and I think, sharing your expertise and your ideas and developing a value proposition is really, a great step forward. And I think Alyssa's kind of going to dive into that on what they've done in that space. So number 7, CBOs may contract with MCOs or VBP contractors. There is flexibility in contracting arrangements. And a community needs assessment is critical to help inform the development of an intervention, and that kind of ties back to the development of a value proposition. I think we all know number 9, but innovative social determinant interventions can significantly improve health in populations and reduce overall costs. And I've heard time and time again from ER docs and the like, if only I could write a prescription for housing, or if only I could write a prescription for healthy food, and that's really what we're trying to do here. And then lastly, in terms of meeting the January 2018 requirement in the roadmap, there is a social determinant of health template where we can kind of understand and gather what interventions will be implemented as we move into the new year. And so existing resources, community-based organizations, so there are a variety of resources, including planning grants, PPS Innovation Fund Awards, and stimulus dollars. So health plans who have VBP level 2 and 3 contract arrangements have received stimulus dollars, 85 million. And so, there are resources, already, in the field, and I think we're, always kind to look how do we improve kind of education resources moving forward. But with that said, I want to turn it over to Alissa so she can talk about In God's Love.
First of all, a huge thank you to the team at AHI and the 2 other PPSs for inviting me here. It's an honor to speak with Liz and an honor to present to all of you. I do work at God's Love We Deliver. I am the Director of Policy and Planning. And God's Love We Deliver is a non-sectarian nonprofit delivering medically tailored meals in New York City. Like so many of you, the learning curve of DSRIP has been huge for our organization, both for myself and my staff. At the same time, I firmly believe in the power of community-based interventions to turn difficult medical situations around for all of the members of our community. So I think as we stand here on the cusp of beginning to pay for value over volume, I acknowledge the many challenges there are integrating the 2, and I'll use the word again, siloed systems of healthcare and social services together, but I think we all know for the good of our clients and for our missions that we have to do that. And so I feel like today what I'm going to try to do is bring some of the practical aspects of what that actually means to all of us together to discuss. So I'm going to think about this more as a conversation. Hopefully we'll have a lot of time for Q&A at the end, but I'm excited. So really quickly, just a little overview so you can understand where I'm coming from. I want to tell you a little bit about God's Love, what we do, our mission, and what a medically tailored meal is. I'm sure that's a new term for many of you in the room today. A little bit about our perspective on what DSRIP is for CBOs, and then some of the practicalities going from the pie in the sky to the what does that mean, the nuts and bolts of VBP. So in service of that, let me just introduce you to our mission through a short video.
In this country, if you're sick between childhood and seniorhood, there's no food support, much less nutrition support. You're on your own. And it's programs like God's Love We Deliver that fill that gap, that recognize that people who are so sick can't do it on their own. They need help.
Have you got the will to survive? Have you got the will to believe you were going to get better? God's love was certainly a part of that, because there's no hint of shame. It's just compassion and help. And how are you going to cope with this suffering?
There was times where I couldn't cook because I didn't feel well. I would drop pots and pans. They said, we don't only provide for you, we'll provide for your children too. I thought it was just amazing because they sent me nutritious, very delicious meals, and it was healthy.
I'm just amazed at how that changed my life. Even on my last birthday, when I was 90, they brought me a birthday cake. Tears came to my eyes, you know.
I would have died, and I know that. Then I found God's Love We Deliver. I was able to eat, and the food is so good. And I got healthy, and because I got healthier, I could start to walk again. My life now is so wonderful.
I'm in awe of our volunteers. They are people of just enormous heart and enormous purpose.
God's Love does something that I've never seen any other type of organization do. You know that when you contribute or when you volunteer for them, the help is going right where it's needed. And you can't put a value on that.
You can see it in the people's eyes when I just give them the bag and they're so happy.
You know, it's such a serious need. They depend so much on these nutritious meals. What would their lives be like without it? Who would care for them?
You get hooked. After the first day
I'm telling you, you fall in love with helping others. This is the place you give.
From the chef, from the staff, from the volunteers, we all come here and do it with love. That's all it's all about, love.
It's not just food. What we are bringing to people is hope and dignity and respect and love. They know they're not alone anymore.
So that's a little bit of an introduction to our mission, and now I'd like to talk a little bit about that mission in action. We started over 30 years ago at the height of the AIDS pandemic, literally delivering to people who were then dying of AIDS. And nutrition turned that situation around for so many of them. And then we used what we learned during that crisis to, about 15 years ago, expand our mission to now serve people living with over 200 different diagnoses. So this is men, women, and children throughout the city, the 5 boroughs, Westchester and Nassau counties, that are struggling to meet their everyday needs. While there is no income or age requirement, which is a big difference between us and other meal programs, I'll talk about that in a minute, 90% of the people we serve live at or below the federal poverty level. So we are talking about the population that DSRIP is trying to move the needle on. And I also want to just point out that we do a lot of driving. So everything on our program is home delivered. We have a huge delivery service area. Our 22 vans are on the road every single day, making sure people get their food. And you can see we do a lot of meals. We do 1.7 million meals a year. So we have nutrition down to a science. So what is a medically tailored meal? The first thing I think that it's important to note is that we believe that food is medicine in a clinical way. We employ 7 registered dietitians, and every single person who comes on our program goes through an in-depth assessment that looks at their allergies, their medication needs, their side effects. If they have a nutrition-sensitive illness, our RDNs are prescribing a diet for them, and then our chefs cook that diet. It doesn't happen exactly in that order, but it's a collaboration between the nutrition side and the clinical side with the registered dietitians. Also important to note is that focus on severe illness as the qualifier to be on our program. So people who come to us have their illness and their ADL limitations. They cannot shop or cook for themselves, certified by a medical provider. So it was wonderful that we had that connection as a foundation as we moved into the world of DSRIP, right? And you can see on the right-hand side some of our diets. No one is put on a diet. We want people to eat their food, right? So our executive chef has a saying, food is medicine, but it doesn't have to taste like it. So I encourage you to know that our meals are really, really delicious. And so we also deliver flexible service plans. A lot of our clients are on seriously intensive treatment, and we have to work around that to make sure they get the nutrition that they need. All of our meals are cooked in our kitchen in Soho. Please come visit. And they're flash frozen, and there are no preservative starters or fillers. So again, good food. This is a snapshot of the different primary diagnoses on our program. This is just the primary diagnosis. Every single person has a severe illness. 90% of our clients are living with more than one severe illness. There's a little snapshot on the right of some of the other comorbidities, but we have plenty of people living with HIV and cancer, or cardiovascular disease and diabetes. And I think it's important to note that I'm pretty sure the behavioral health number is underreported. So we're really serving the sickest of the sick in our communities, those that are the highest need, highest cost, hardest to manage people because of the complexity of their illnesses. These are the 5% of people that are costing 50% of the healthcare budget, that left-hand side of the circle. I think it's helpful to think of our services as a spectrum. Food as medicine is a spectrum, from prevention at the bottom of this pyramid, where I think we all in this room believe people deserve access to healthy food to prevent chronic conditions and encourage health, all the way to treatment at the top, where someone is too sick to shop or cook and may have a nutrition-sensitive illness that needs an intervention that's more of a treatment than prevention. And that's where God's love lives. So surprisingly, there is no dedicated federal benefit for what God's Love does, except for people with HIV. So God's Love actually raises 65% of its budget every single year to deliver this kind of care to people. So we are solidly in the nonprofit world. In fact, I'm going to pause for a second. Who in this room is a nonprofit CBO? Raise of hands. Awesome. I hear you. The Affordable Care Act also didn't include any specific innovations that dealt with nutrition. So it's really been a state-by-state innovation, and we are very fortunate to live in a state and serve in a state that has recognized the value of social determinants of health, recognized the value of nutrition and other community-based interventions in accomplishing our healthcare goals. So for God's Love, one example of that is our partnership with Medicaid managed long-term care plans. So our partnership started in 2005, and since then, as you can see from the graph on the right, have just grown. And this is where we partner with those plans to serve their most ill members, help keep them in their homes and out of more expensive forms of care, which is good for the state, the plan, and especially our patients. Our clients do not want to go to the hospital. They want to be in their homes, right? So anything we can do to help facilitate that, we look at as a good thing. One thing I want to point out here, though, is that there is no mainstream population on this page, and that is a huge population for God's Love, right? That is 90% at or below the federal poverty level. And with the increased choice and flexibility in our Medicaid program, a lot of the people in the mainstream program are also very ill. So we believe very strongly in backing up that treatment to before people become so sick that they fall off that treatment cliff. And so with the opportunities afforded by DSRIP and VBP, we've worked hard to be at the table to make sure that the needs of our clients are represented. So let's dive right in and talk about this wonderful acronym. So God's Love We Deliver, early on in the DSRIP process, we've been part of it for the last almost 4 years now. I know we're only in year 3, but it started in year 0, so it's been a long road for us. And we noticed at the beginning that many hospitals and the PPSs that were forming didn't really understand the data, and I use that specifically around the impact of food insecurity and malnutrition on health outcomes. So we found that it was an imperative for our clients and our mission, and also the future landscape of healthcare, to make sure we were at the table to talk about that data, to say, hey, you need to screen for food insecurity, otherwise how will you know? And other things like that. So we have a whole team of our staff, and our staff have adopted different PPSs, and we are part of 12 downstate. Remember, we're a citywide agency. You don't have to be part of 12, but because we had clients in all of these areas, we found it necessary. Multiple committees and lots of meetings. But one of the advantages of that was education, was learning a lot about DSRIP, learning a lot about the goals of the state, learning a lot about the metrics that PPSs are being held accountable for, and then understanding how our program might influence some and not influence others. Since that time, we've been approached by several IPAs and ACOs about VBP. We were featured by the state, got to work with Liz on the webinar. We've constructed a formal cost-benefit analysis, and we've made certain internal operations changes to be ready for a value-based contract should that come. But I want to be clear, we are not yet engaged in a value-based payment contract, so I'm probably very similar to some of you in the room where we're still working out those details. So I want to acknowledge up front some of the feelings you all may have in the room that I, as a part of a CBO, also had going into this, and then talk about what the solutions to those barriers might be. So a gentleman in the previous session was talking about some of these barriers, but I thought I'd make them a little bit explicit. So one of the things that we keep talking about is how healthcare and the social services world don't talk to each other. And a lot of that has to do with data, but a lot of it also has to do with the questions that we ask clients, right? There's a huge push to actually have a social determinants of health screening, that top bullet. And even if there is in a hospital, staff may not be trained to know what resources exist in the community. And if they do know what exists, they might make an improper referral because they don't understand what services you provide or the population to which you provide it. And then once you train a whole coterie of staff, there's staff turnover, so you have to do it all over again. And then finally, I think one of the fiscal strain of providing more services to more people. And then in terms of being effective partners, we keep talking about outcomes data and proving that your intervention works. And one of the things, as a research-minded person, I really like data, so does everybody at God's Love, by the way, is that the outcomes data rests with the healthcare field. So you can deliver all of the food and all of the housing and all of the transportation you'd like, but you don't know if it affects whether they went back to the hospital without a relationship. And it's those relationships that are what I believe DISRIP is trying to facilitate and are what we all need to take advantage of. So, the solution. Not a simple solution. Very much the healthcare world is an ocean liner, not a motorboat, to use someone else's phrase. But we also have to understand that DISRIP really is the laboratory to test new models of care, to try those pilots on discrete populations and kind of isolate the variable maybe. And also to, most importantly, work out those data problems, help the hospital system understand what they need to ask, and then if they ask, how to refer, and then once the referral is complete, how to close that loop, and then finally, getting some outcomes data. And so I just want to remind us as we move into what this practically means, that what Liz just mentioned, that by January 2018, this is what VBP contracts in level 2 or 3 are requiring. So there is tremendous incentive to make these partnerships happen, and that's very encouraging. So, as I said, I want to try to go from pie in the sky to facts on the ground, and talk about some of the key questions that you should be asking your organization or could be asking your organization as we start down this path, and then further considerations once you've really deeply considered those questions. And I do want to remind everybody there's going to be plenty of time for questions at the end, and I'm sure there will be quite a few. I also want to say this is largely taken from our experience being contractors with Medicaid managed long-term care plans over the last 15 years. These are very, nuts and bolts kinds of things that we have noticed over time were necessary for us to do or to notice or to learn, and I hope that they're helpful for you. So first, I think it's really important, and Jason mentioned this in his whiteboard video, to start with your fiscal considerations. Start thinking about the risk question, and also thinking about your costs as you go into a contracting atmosphere. And I want to say that God's Love has considered all the questions that I'm about to talk to you about very, very deeply and gotten very, very clear on what our answers are to those questions so we could be more effective partners going forward. Those answers have formed a lens for us as we approach partnership to say yay or nay or maybe or let's talk more. And I think that they're very, very valuable. And so let's jump right in. Number one, how will you pay for your services? Very, very important, especially as stewards of missions. We have to be able to deliver on those missions. So a couple of sub-points to that. Obviously, there are many different ways to partner, as Liz pointed out, with value-based payment contractors. I think in the second Social Determinants of Health boot camp, there was even an example, and I'll talk about that in a minute. So are you willing to use other funding streams to supplement the VBP contract, or do you expect full reimbursement? Very key question, and you may be in the former group. Even with direct contracting, you may not get paid for a while. So do you have the resources to deliver that service and then get payment later? Remember that even if you don't contract or are not reimbursed for services, the contract needs to be about outcomes and needs to focus on the research that you're going to get out of that. Remember, prove that it works. That's the thing I want you to remember as we go through this. This is the opportunity to break down that wall where we're not talking to each other and to get that, to close that loop on data. Very exciting in my mind. Now we get into risk. Can you, as an organization, even think about accepting downside risk? This may be an absolute yes, or a total no, or a maybe. You may be willing to absorb some of the downside risk, but not all of it. These are all conversations that you have internally as you begin this process. And then lastly, do you want upside risk? Are you even interested in that incentive payment? Or are you confident and excited about having a pure reimbursement contract? You may not be able to answer all of these questions right now. You will revisit them as you continue down the road, depending on what your relationship is with the contractor. So I want to also say that there, in addition to the wonderful resources from the state, thinking about social determinants of health and investing in results and pay for performance is a national trend. I will say New York State is far out ahead. There are nonprofit resources also that are thinking this through and trying to help CBOs and nonprofits figure out the fiscal side and the operations side and all of these other things. And so I'm happy to share some of those resources if it's helpful for the group, but I encourage you to bring that information to yourself because it can be very instructive. So once you've deeply considered those foundational questions, it's time to move on to some more. And again, these are not exhaustive by any means. They are designed to provoke your thoughts and your conversation with your organization. So the first one is populations and services. And I want to hearken back to understanding insurance, understanding DSRIP. If you're part of a PPS, understanding what projects that PPS has adopted, understanding what metrics the state is holding them accountable for, and understanding what metrics they're falling short on. So there's a lot of education of ourselves that we have to do to understand our partners. So the first bullet here is what population is the VBP contractor even interested in? Is it a population you serve? If not, are you willing to serve that population? Is it all diseases or a specific illness? Are comorbidities involved? Superutilizers, demographics, and then my favorite bullet point, I know I keep harping on research, but you have to start thinking about evaluation from the very beginning of your thought process so that at the end you're actually measuring the thing you want to be measuring. And then just thinking a little bit about a cost-benefit analysis and the time frame you might need to see those results. Purpose of services. So are you going solidly for the triple aim where you're reducing costs and improving health outcomes and making people happy? Or are there, again, those specific metrics that the PPS or the VBP contractor or the hospital, the ACO, the IPA, we'll get to all those acronyms in a second, is looking at? Reducing hospitalizations, obviously as a state we're trying to do that. Medication adherence or end-of-life care, making people happier and healthier as they reach the end of their lives. And then this slide is kind of funny. I put grocery bags in there because God's Love doesn't really do grocery bags, but what if we could do grocery bags? This is the point I think that was being talked about on the whiteboard video. Maybe stick with your core competency, but maybe you have a little wiggle room. You have to acknowledge that and decide that on your own. And another thing I think is important to think about is, as you're proposing a service, will you be partnering with other CBOs in your area to make it a comprehensive social determinant of health intervention? There are pluses and minuses to both sides. If you're providing just your intervention, you can isolate that variable and really just measure that intervention, but there's benefit to really addressing the client's whole needs. So those are other considerations. Programs and services changes also necessitate operations changes. If you're delivering a direct service, this becomes even more important. So This is my Slinky slide. How flexible can you be? And I think this is about being creative in thinking about how your services fit into an existing care model. Might require a little yoga. But it is more than likely that there are ways that you can integrate your services into the care model, but you have to think about what the healthcare provider must deliver on also. So I think the best way to talk about this is actually a little bit of an example from God's Love. Remember I talked about our Managed Long-Term Care program. We call it our Community Partners program. But when we began partnering with healthcare, we had to be responsive to each plan's needs. So we have 30 plans that we contract with. That's a lot of different needs that we were responding to, and no two plans were alike. And we needed dedicated staff to manage all of these changes and make sure we were doing the right thing for the right contract. So we added weekend meals, we modified our breakfasts, we added beverages. People on our program can get anywhere between 1 and 21 medically tailored meals a week, depending on their needs. They may have a family member that comes in on the weekends and actually cooks for them. We don't want to duplicate services, so we had to learn how to do that, both from the operations side and the system side. And then nutrition, we're very protective of the nutrition part of our program. That's why we employ registered dietitians. But if a plan has one and is willing to work with our dietitians, we were willing to do that. New delivery options. I mentioned our 22 van fleet. We had to align with home health aid hours. So if someone has a home health aide that's in their house, say 4 days a week, both delivering or cooking for them and also taking care of personal care needs and other things, but they don't have one 3 of the days of the week, we could deliver meals the day the home health aide was there for the days they weren't. So then the home health aide could store it properly, make sure the client understands how to reheat, food safety, etc. It was awesome. But that required a change in our program. And then our expansion to Westchester and Nassau counties. That was a really big operations change and ended up being very successful. But when you're delivering door to door, it's a lot to go all the way up to Westchester County for one person, right? So we had to manage all of that. And then most importantly, customer service. So we realized pretty early on that we were actually responsible for being kind and courteous customer service representatives, not only to the patients and the clients that we were working with, but also the plan. There's a whole other side now that, of relationships that we're concerned about with care coordinators and plan representatives. We wanted to make it as easy as possible to partner with us. So we helped care coordinators by designing a custom referral tool using the uniform assessment system, which all MLTC clients must go through, which really helped. Many care coordinators came to us and said, how do I know who to refer? Well, we helped them with that. Streamlined authorization, referral forms that had the information the plan needed. And then we do all sorts of ongoing education. We invite people into our kitchen. I also encourage all of you to come visit our kitchen. It's lots of fun. And then some of the other things, like making sure that if a client didn't show up for their meals, we were able to reach out to the plan. We're often the first people to know if something's wrong with the client, so that ability to be super responsive, even in the evening hours, was really important. So at the end of some of these sections, I've just posed some questions for you all to consider that might help you and your teams start to think through some of the operations changes that might be necessary. Again, not exhaustive, but they helped us as we were going through this process. Okay, this is my favorite part. Are you ready? It really is, because I think that many people assume that there is no data when it comes to social determinants of health. But how do we know then that 60% of our health is attributable to our social surroundings and many other things? The actual answer is it's the exact opposite. There is so much data about the efficacy of social determinants of health, and it's out there, and we just need to utilize it. As was mentioned in my very kind introduction, I head up our national coalition, the Food is Medicine Coalition, other medically tailored meal providers in other cities. And there are 4 new research studies that just came out. And this field of social determinants of health and community-based intervention is really burgeoning right now. There's so much coming out every day. So I encourage you to look out there, and that's what we're going to talk about right now. So I think we've already talked about knowing the metrics that you're trying to address, and that involves us educating ourselves and being good members of our PPSs. And then know the research in your field. I can share with you how we bring research to us, because I know we all have day jobs, right? We all have to actually deliver services. But you can subscribe to listservs. The MRT listserv is a great way to know about opportunities. Medical journals, social determinants of health journals, you can get alerts. There's so many ways to bring research in the field to your fingertips. And don't discount the research at your program. If you do a client satisfaction survey, or you take a read of whether people like the food you're serving or don't, there's so much data we collect that we don't even think about that can be leveraged to talk about the value of your services. So I think for illustration purposes, I'll just do a really quick value proposition. So food is medicine. This is about making the intuitive explicit, right? When you're making a value proposition, everybody knows healthy food makes you happy and healthy, right? But what are the actual outcomes of feeding someone a healthy diet? Well, we know that it's critical for the management of chronic illness. In fact, research shows that it is absolutely paramount to the accomplishment of the triple aim, which I believe our keynote speaker spoke about, and I also still believe in it. That being said, here's a little short summary of the research in the field. I do much longer presentations, I do much shorter presentations. This is just a snapshot. On the left, you have the research that pinpoints the problem. People who are food insecure don't adhere to their medications. They don't control their chronic conditions. They go in and out of the hospital. And malnutrition. Malnutrition is an epidemic in our country. 1 in 3 people are hospitalized with malnutrition in our country, right? That's crazy. And people who are malnourished are 50% more likely to be readmitted. That is the metric we're trying to move. And so what is the solution? Well, research has shown that people who get a medically tailored home-delivered meal see a 28% drop in their health care costs. They don't go to the hospital half as often. And when they are discharged, they're more likely to go to their home. And that satisfies 2 different metrics, right? Happy people, because they want to be at home, and fewer costs. And then for people with HIV, there's a lot of research on people with HIV, and the adherence data is really convincing. So this is kind of a smattering, but a little bit of a condensed smattering. And you want to decide what you want your audience to go away with. And I just want to thank you, Liz, for saying this before I did, because I want you to go away with remembering that nutrition is an inexpensive intervention. You can feed someone for half a year for the same cost as 1 night in the hospital. And the return on investment is very, very fast. You can see results in up to 30 days. So that is just a little small, sorry, that is just a short value proposition, but it doesn't have to be a formal cost-benefit analysis. It could be if you have that data, but it has to be enough and thoughtful enough to make the case about the value of your services. So here is some questions for discussion. Just thinking about the data that you might not have thought about, right? Do you administer a client satisfaction survey? Do you know people that are doing research, etc.? So I hope that that's helpful. So we come to the data and the IT piece, which I think is the area that has almost as many challenges as it does opportunities. And so I'll talk a little bit about what we had to do on the data side, and I just want to emphasize that we are still in process. We are still working with our PPSs and regional health information organizations to make sure that social determinants of health as we see it is incorporated and that we get the data we need to be able to deliver our services. So, what data do you need from the health provider to deliver your service? This is all part of the contract. What data does the health provider need from you once you've delivered the service or as you're delivering the service? And how will you exchange this data adhering to patient privacy laws? I really want to highlight this bullet because we started at the height of the AIDS pandemic. Confidentiality and privacy is absolutely paramount for our clients, and this has been our most important question. So many of the PPSs you may work with are asking you to sign things like business associate agreements and other things. Has anyone come across that? Raise of hands. All right, awesome. So you know what I'm talking about. These are all things that govern privacy and information sharing and who's part of whom, and it's important to educate ourselves about that. And then again, proving that you made a difference, highlighting the proving that you made a difference point. How will you get outcomes data back? Or how will you partner together to show outcomes data together? So here's a little bit of an example from us and where we had to make some changes. The first bullet is not a change. That's always been the case at God's Love because of our history. But we had to start using billing forms, which required a whole billing system, and keeping track of meal days versus delivery days to avoid duplication of services. And then many of the contracts we signed had different requirements, like for one, our drivers had to wear God's Love branded clothes, you know, and identify themselves when they came to the door. All things that weren't egregious at all, but had to be thought about and mindfully kept track of. So here's some more questions about data and IT. What capabilities do you already have, and what might you need to add, thinking of those billing systems? Or another great example is just collecting Medicaid IDs. It may be a big deal to do that, right? But that may be what you need to do to effectively partner with healthcare. And then most importantly, down at the bottom, I encourage you to investigate not only the resources from the state, but also pro bono resources in your community. Legal resources, operations resources, there's a lot of help out there, for sure. And finally, we come to the handshake. This is my last section, I swear, and then you can all pelt us with questions. This is where you form the relationship and you negotiate that contract and you get to a place where you mutually are in agreement about the project that you're going forward on. So first, who are your targets? I think we have talked interchangeably about PPSs and value-based payment contractors, but really value-based payment contractors can be a variety of entities. They're not necessarily your PPS, actually. I would encourage you to look at innovations funds from your PPS, but become aware of who in your regional area is actually participating in value-based payment. So I think it's important to, going back to those key questions and some of these categories that we've talked about, know what you can do as you go in, getting really, really solid about what you feel you can offer from a value perspective, from a program perspective, to influence the metrics, etc. And then I will say, please hire appropriate legal counsel as you enter into contracts. That's actually very important. I am not a lawyer, so I highly recommend doing that, and that is where pro bono resources do come in. And start the conversation. Remember that this is a relationship and a conversation, and it doesn't stop with a no, right? You can follow up and talk things through and renegotiate. And as you make the decision, you may come across things that you did not anticipate, and you'll have to revisit your core questions, the lens that you see yourself through, and renegotiate or stay firm. As I said, not taking no for your final answer is really important. And then finally, understanding when you need to walk away. And this comes back to your lens. You know, when it doesn't make business or mission sense for you, that's a threshold you will define. I want to say to the little picture over on the right, it's so important to over-deliver on your contract, to be really aware of the fine print, to be good contracting partners, because I think that it fosters an increased understanding that these relationships can work. And if you stick to that principle, you will be successful. So just a quick summary, and then Oh, good, we have some time. Then we can take questions and answers, but we've covered a lot today, so I appreciate you sticking with me. And we've gone through the view of DSRIP really as the laboratory. I just want to highlight that again. And then talked a lot about some key questions: population, services, data, NIT, crafting your value proposition. And all of this goes into kind of the whole process ending in potentially a good relationship with a healthcare entity where you are serving your clients and also making the case that your intervention works, so that more people can receive your services in the future. I fully believe that this is a valuable process, and I encourage you, if you haven't already embarked on it, to start the process. The water's fine.